Moving on to Chapter 6, I talk all about the central venous pressure. And in this overview, I'm going to talk a little bit about the determinants of the central venous pressure. And so firstly, the central venous pressure, which is what we measure with a fluid-filled catheter placed usually through the SVC down to the cavo-atrial junction. This pressure that we're using is a surrogate of central venous volume. Remember, pressure and volume are related by compliance, and just for simplicity, I'm going to ignore the impact of caval compliance and say that central venous pressure is what we're measuring as a surrogate of the central venous blood volume. And so if you think of what are the determinants of volume in the thorax, well, it's going to be, if you think of the right atrium as like an eddy in a stream, then the volume in the right atrium is going to be a combination of inflow going into the thorax and thoracic outflow. That's your and so this is your venous return, and this is your cardiac function. So if you're pushing a lot of blood into the thorax, your central venous volume, but at the same time you're pumping a lot of it out, well, then your central venous volume may remain the same or actually even decrease. Conversely, if you have a little bit of inflow to the central venous space and at the same time your heart's unable to pump it out, well, then oddly enough, your central venous blood volume and therefore your central venous pressure may actually increase. So what is this? Well, this is the Campbell analysis. This is the Guyton analysis. So this increase of this increased flow or this increased volume into the right atrium can be depicted here by the Guyton diagram. So again, this is your venous return curve. This is your mean systemic filling pressure here on the x-axis. And this is determined by the stressed volume over your venous compliance. So the higher your stressed volume is, which is a marker of your volume status, whether you're hypovolemic or hypervolemic, the stressed volume determines this pressure head. This is the pressure head for a return back to the right heart. So if I were to give this patient a few liters of crystalloid and increase their volume status or make them hypervolemic, I will increase their stressed volume, I will shift their venous return curve rightwards, and therefore for any given downstream pressure, which is your right atrial pressure in this situation, remember this is the pressure up here, moving in this direction would be your mean systemic pressure, and then your downstream pressure will be your right atrial pressure here. For this venous return curve, there's a greater flow for a given right atrial pressure. Similarly, if you were to lower your mean systemic filling pressure, say by going into hypovolemic shock, well then your venous return curve would shift leftwards and there'd be less venous flow for any given right atrial pressure. But at the same time you have to take into consideration what is coming out of the central space, and that is determined by the Frank-Starling mechanism. So in this patient with this curve, the higher the right atrial pressure, the greater the output, and this is induced by stretch-induced calcium sensitivity. In this patient whose cardiac function curve is shifted up and to the left, increased cardiac function, well, they have a greater outflow for the same right atrial pressures. This patient whose heart cannot pump blood out of the central space as well, then this patient will have less outflow for a given right atrial pressure. And so therefore you can see that the volume in the right atrial pressure and therefore the blood volume in the right atrium and therefore your right atrial pressure or your central venous pressure is determined by the relative inflow, your venous return curve, and the relative outflow, your cardiac function curve. So putting this together, you can imagine a patient like this one here who will say, for argument's sake, this is a euvolemic venous return curve and this is a normal cardiac function curve. This patient has this right atrial pressure for this cardiac output. Okay, the right atrial pressure, even though it's on the x-axis, the right atrial pressure is not an independent variable. So there's this tendency in our brains to think that if it's a variable on the abscissa, then it is an independent variable. But the right atrial pressure in the Guyton analysis is not independent. What the truly independent variable is the mean systemic filling pressure. That's what you're altering, shifting this curve left and right. Similarly, for the cardiac function curve, shifting the cardiac function curve up and down is really the independent variable changing your cardiac function, and then the right atrial pressure is an innocent bystander. So if you were to take a patient and watch this arrow, increase their venous return, say by giving them a ton of fluid, well, you may increase their mean systemic filling pressure. You've given them a bunch of crystalloid, and so now their venous return curve shifts rightward. But if they simultaneously increase the outflow, watch this arrow, if they simultaneously increase the outflow, well, it's going to be a wash. They'll have the same central venous volume and therefore the same central venous pressure. So two different patients, one's hypervolemic, same central venous pressure, and that's because you can only interpret your central venous pressure when you know your cardiac output, or at least your cardiac function. Similarly, watch the inflow arrow. If you were to make somebody hypovolemic, so they have much less venous return, you shift their venous return curve leftwards, but you concomitantly reduce their forward flow by giving them, say, a poor heart. Well, look, all these patients, hyper, euvolemic, and hypovolemic, all have the same central venous pressure, and you have to understand, therefore, that the central venous pressure is not a marker of your volume status. And Sheldon Magder, who uses the analogy that you have to think of the CVP as like your pH. And your pH varies as a function of multiple physiological determinants, much like the CVP does. So asking what the patient's volume status is from their CVP would be like giving you the patient's pH and asking you for their lactate concentration. It doesn't make sense. Lactate certainly plays a role in a patient's pH, as volume status plays a role in the patient's central venous pressure, but there's multiple mechanisms at play here. So there's a very important caveat to the Guyton analysis that we just looked at in the previous slide. That caveat is that what that caveat is we've said is a lot. The right atrium is not exposed to atmospheric pressure. On the Guyton analysis, the pressure that you're measuring, the CVP or the right atrial pressure, is presumed to be the true transmural pressure, which is not necessarily true when you place the right atrium into the thorax, because the thorax is slightly subatmospheric. So you have to realize that there's a difference between what you're measuring from the CVP catheter and what the true stress on the right atrial and right ventricular wall is. And this is introduced because of this measurement artifact. The central venous pressure can vary widely between inspiration and expiration in a patient making active inspiratory and expiratory efforts, which is common in the intensive care unit. In this situation, the central venous pressure no longer reflects central venous blood volume, but instead intrathoracic pressure. And relying on a central venous pressure taken in the aforementioned scenario is mostly meaningless. So I want you to consider the following graphical explanation. Well, here's a Campbell analysis, okay, and we're going to take a look at this patient from the standpoint of what increased airways resistance would look like. So go back to chapter 5 and picture this patient with a COPD exacerbation and how their Campbell diagram might change. Well, this curve to the left here represents increased airways resistance because it requires a lower pleural pressure to drive flow. Remember the pulmonary elastance curve and the chest wall curve. These curves determine the pressure-volume relationship of the lung and chest wall, but these curves here determine the pressure-flow relationship. This is the dynamic component of your intrathoracic pressure. So this patient here has a higher airways resistance. More negative or lower pleural pressure must be generated to maintain the same flow at the same volume between these two patients. Okay, so this is increased airways resistance. While expiration is normally a passive event, so you've inspired and now you're at this higher volume, and then you expire down this passive elastic recoil of your lungs, patients in the ICU tend to have to maintain a very high minute ventilation, and they bear down and grunt and force out their expiratory flow, and they do this by recruiting abdominal muscles and accessory muscles of expiration, and you'll see in these patients they'll actually drive their intrathoracic pressure way up. Remember, this is 0. This is above atmosphere and this is below atmosphere. So this patient bears down and on expiration has a very high intrathoracic pressure. So let's watch this patient take an inspiration and expiration. So they inspire and then they expire, and this is and they inspire and expire, and this is what's happening in their with their intrathoracic or pleural pressure during inspiration and expiration. So if you now drop that graph down onto the z-axis into the page, you can see inspiration, expiration, and that dot is FRC. Now superimpose the Guyton analysis. Well, this dot here, this is the CVP that you're going to measure with your triple lumen catheter. Why? Because this pressure here is relative to atmosphere, and atmosphere is this pressure here. Remember, this is 0. This is above atmosphere, this is below atmosphere. So this pressure here, you would actually tend to underestimate your distending pressure in this patient because you're only measuring the pressure above atmospheric pressure. The intrathoracic pressure here at FRC is slightly subatmospheric, and this is the pressure as depicted by the x-intercept of the cardiac function curve. So the transmural or distending pressure is actually a little bit higher. Well, watch what happens when this patient makes a forced inspiratory effort to the CVP. So now they're going to make a forced inspiratory effort. So the cardiac function curve shifts leftwards in response to the drop in intrathoracic pressure. The measured CVP is actually now subatmospheric. So your CVP on the monitor may say -5 or whatever. It doesn't really matter for this illustrative depiction here. -5, but we're ignorant to this value. We don't know how low the intrathoracic pressure is, so we don't actually really know this true distending pressure of the right ventricle and right atrium. So if this is actually -20 and this is -5, well, the distending pressure is actually 15, and that would be equivalent to opening the chest, exposing the heart to atmosphere, and then putting in 15 millimeters of mercury of pressure into the right atrium. It's physiologically the same stress on the right atrium and right ventricle, despite measuring a CVP of subatmospheric. And this is important to bear in mind, that this is just a measurement artifact. For similar but opposite reasoning, a forced expiration as this patient grunts and bears down and increases their intrathoracic pressure, well, now what's the CVP that you're going to measure? There may be simultaneous, because of inspiration and expiration, there's simultaneous changes in the venous return and cardiac function curves. I'm not going to get into why they occur, but you can see why that occurs in chapters 3 and 4. But this forced expiration, you now measure a fairly high central venous pressure, but that is mostly a reflection of the high intrathoracic pressure. So this patient's preload is actually very small. So if you measure this CVP to be 20, but the intrathoracic pressure here is 15, well, the distending pressure is only 5. So this patient would be, despite having a very high CVP as measured on the monitor, this patient's distending pressure would be equivalent to opening the chest, exposing the heart to atmosphere, and filling the right ventricle with 5 millimeters of mercury of pressure. So even though this CVP is higher measured than the inspiratory CVP, the stress on the right ventricle is actually much, much less. I'm being maybe a little bit flippant here, but it's essentially a meaningless number. It just tells you, when you see this number and when you examine the patient, that the patient is just bearing down. So in chapter 7, we're going to talk about the pulmonary artery catheter, and this is the sailboat that Dr. Swan saw in the ocean in Santa Monica, sailing along, which gave him the idea to put a little balloon at the tip of the catheter and let it float into the pulmonary vascular tree. And I talk about all the aspects of the pulmonary artery catheter, or not all of them, but I try and touch on a lot of the highlights. And what I would like to talk about here in this introduction section is, it kind of flows from what we just talked about in terms of the central venous pressure, but as it applies to the pulmonary artery occlusion pressure. And so the pulmonary artery occlusion pressure, which I abbreviate P subscript Pao, is, I find, often the most sought variable from the pulmonary artery catheter, but ironically it's probably the most misunderstood in terms of measurement and interpretation. And this will lead to erroneous clinical decisions that come from measurement and interpretation errors. So the first part of the talk on the pulmonary artery occlusion pressure in Chapter 7, we talk about the principle behind accurate measurement of the pulmonary artery occlusion pressure, and then move on to interpretation. So here in this brief overview, I want to talk about measuring the pulmonary artery occlusion pressure. So how do we do that? Well, when you inflate the balloon at the tip of the pulmonary artery occlusion, or the tip of the pulmonary artery catheter, that's PAC, after the tip of the pulmonary artery catheter has been advanced into the pulmonary tree, blood flow has ceased beyond that balloon, and a static column of blood is generated between the distal port of the pulmonary artery catheter and the J1, or first junction, of the pulmonary veins, which essentially gives you an estimate of your left atrial pressure. So this is sort of like the CVP of the left atrium. But accurate measurement of the pulmonary artery occlusion pressure requires consideration of the following. Firstly, like the CVP, the pulmonary artery occlusion pressure will be affected by the physical relationship between the catheter tip and the transducer, and I talk about that in Chapter 6. Like the CVP, the pulmonary artery occlusion pressure will be affected by intrathoracic pressure, which I'm going to illustrate for you on the next slide. And the pulmonary artery catheter must be in West Zone 3 physiology. And remember, and I have a cartoon for this in Chapter 7 itself, but remember that West Zone 3 physiology occurs when the pulmonary arterial, pulmonary capillary, and pulmonary venous pressures are all greater than the alveolar pressure. So they're in this situation, when the pulmonary artery catheter is in this blood flow physiology, there will truly be an uninterrupted column from the tip of the pulmonary artery catheter all the way down to the J1 junction. If it's in West Zone 2 or West Zone 1 physiology, the pressure that you're measuring at the tip of the pulmonary artery catheter is actually not an estimate of the left atrial pressure, but instead an estimate of your intrathoracic pressure, or I should say alveolar pressure. So what does increasing your intrathoracic pressure do to your pulmonary artery occlusion pressure? Well, this is a healthy patient with a normal Campbell diagram, and you were to just increase intrathoracic pressure without changing thoracic volume. So this is, in effect, a Valsalva maneuver. Well, I'm going to illustrate, this might appear a little bit complicated on the surface, but I want to illustrate what this increase in intrathoracic pressure does to both the right ventricular cardiac function curve and the left ventricular cardiac function curve. So I'm going to kind of superimpose them on the same venous return curve. So this is your right ventricular cardiac function curve. Again, this is the distending or transmural pressure. This is the pressure that you would measure off of the pulmonary artery catheter, your CVP, or right atrial pressure. And then when you perform this increase in intrathoracic pressure, the right ventricular cardiac function curve shifts rightwards, and we're assuming that there's no change in the venous return curve with this change in pressure, and there really shouldn't be because there should be no change in abdominal volume. And the transmural pressure of the right ventricle and right atrium is diminished. So now I'm going to superimpose the left ventricular cardiac function curve on the same venous return curve, and that's a little confusing, and I apologize for that, but what this should demonstrate, or what this should mean, is this venous return curve, as it applies to the right ventricular cardiac function curve, this venous return curve represents systemic venous return, and as this venous return curve applies to the left ventricular cardiac function curve, this venous return curve implies pulmonary venous return. So the drop in right ventricular volume may result in a brief increase in left ventricular compliance and therefore stroke volume. So your pulmonary artery occlusion pressure might actually decrease a little bit. It'll move from here to here, and that's just simply a function of a brief improvement of your left ventricular compliance. If the left ventricle becomes more able to accommodate blood, its pressure will drop for a given volume, and that is via ventricular diastolic interdependence. But the pulmonary venous return curve and the left ventricular cardiac function curve shift in parallel with an increase in intrathoracic pressure, and that is in contradistinction to the right ventricular cardiac function curve and the systemic venous return curve. And the reason that the pulmonary venous return curve and the left ventricular cardiac function curve shift in parallel is because they are both subjected to the intrathoracic pressure. It's different for the systemic return because the increase in intrathoracic pressure is which affects the right ventricular cardiac function curve, is different from the pressure that is affecting your venous return curve, which is for the most part abdominal pressure. So when you increase the intrathoracic pressure, these two curves shift in tandem. And so they're actually, despite the increase in your wedge pressure that you're measuring, there's actually really should be little or minimal change in the transmural pressure or distending pressure of the left ventricle. So while there's no true change in the distending pressure of the left ventricle with the increase in pulmonary artery occlusion pressure as a result of simply an increase in intrathoracic pressure like with a Valsalva, while there's no change in the distending pressure, this measured increase in your wedge pressure will represent an overestimation of the true distending pressure. How can we account for that? And again, both intrinsic and extrinsic people will produce this physiology. Well, there's this neat calculation you can do called the index of transmission. And the way this works is you essentially give a patient a breath, and then you have to do some conversion between centimeters of water and millimeters of mercury. But you can estimate how much of the airway pressure is being transmitted to the pulmonary vascular space by doing the following. So you measure your wedge pressure at end expiration. You measure your wedge pressure at an end inspiratory hold. And what you do is you measure the change in airway pressure while simultaneously measuring these changes in wedge. And so say for illustrative purposes, this patient has a PEEP of 5. So their airway pressure is 5 centimeters of water. And then they have a plateau of let's say 18. So 5 to 18 is of centimeters of water is the change in airway pressure. Well, that's a change of 13. 13 centimeters of water is equivalent to 10 millimeters of mercury. So this change in airway pressure converted for millimeters of mercury is 10. And I've done this to make the math easy. Now say your wedge here was 5, and up here it was 8. Well, your wedge has increased 3 for an increase in airway pressure of 10. So that is a transmission index of 3 over 10, or 0.3, or 30%. And then you can use that as an estimation of how much of the airway pressure is affecting your wedge pressure. Yeah, just that. Again, this method requires a completely passive patient with the ventilator. If the patient is bearing down or generating significant respiratory effort, the use of the pulmonary artery occlusion pressure as a marker of left ventricular filling pressure is exceptionally flawed. And that's it for the introduction for chapters 6 and 7.